So it gives me great pleasure to invite a friend and a global leader in harm reduction. It's going to be Mr. Ernst Wisse from Medicines du Monde, who is a leading harm reduction expert. Ernst, where are you?
Hi, everybody. I have only 50 slides to go through, so I hope you're all well set. They told me that thing is going to explode in 20 minutes, so I'll flip through the first ones very quickly because they were only really to show you that I've done my homework, but you will hear all of that a lot throughout the conference, the number of people who use drugs, the number of injecting drug users, and of course we will talk a lot about prevalences. Just a quick note that I think we don't speak enough about recent skin infections and overdose, but we will speak a lot about, surely, hepatitis C and HIV. So I'll quickly go through the global state of harm reduction. You're all familiar with these reports, obviously. Just to make a very quick note that in the past years we see a steady, slow increase of countries endorsing different services, as you can read on the slide, that we're all quite aware of. I also want to quickly pull up this systematic review that looks a little bit more into coverage, because there's one thing having an NSP service in a country is a whole other world to make sure that people actually have access. Oh, I see so many friends in the room. It's great. I'm looking forward to speak to you after this presentation. Just to draw your attention to that right top section of this fancy graph that looks at high coverage NSP, high coverage OMT. Of course, we want everyone to move into that corner. At the moment, this is still a very high-income country business. We really hope to see that growing towards that top right section. But I also want to make a quick point that if we talk about high coverage NSP, we often put a benchmark around 200 or 300 syringes, and I think we're all aware, if you're a daily injector, 200 syringes means that you get less than one a day, so that can't necessarily be called high coverage. So I just want to make that point that maybe we want to look into a box even a bit higher up in that graph. Same story, we're aware with the global health sector strategy targets. We are, the last known number, as far as I'm aware, is still only at 35 on an average, which should be wildly higher than that. And yeah, bit of a reality check. This is a report, I think from 2023, if I'm not mistaken. Total funding for harm reduction in low and middle income countries is only 6% of what is needed. But the reality is obviously we've all had a pretty shitty year, right? We've seen a lot of programs ending. We've seen a lot of people really struggling to keep the services running. This was one of the first reports that I've seen from input. There's other reports coming out, and I think we will only really see the full impact in the coming years. I've seen only one modeling study so far that speaks about what the impact ultimately will be. That states that if nothing changes and there will be no replacement for that funding, there will be an additional 4 million AIDS-related deaths in the coming years. And even if treatment will be restored by other funding means, if the prevention, which is relevant for harm reduction, if that will not be refunded, we're looking in at least 1 million or around 1 million more infections in the coming years. So it's a harsh reality check, but this is really what we're looking into. Now, as this is a topic, obviously, which is highly perceived by morality, evidence is often our only weapon to try and change people's minds. So just very quickly going through this, but I realize I'm standing here in a room full of scientists, so I'm not going to explain your own slides. If you recognize something, these are your slides. So just quickly, I made it even busier. It was already a busy slide, and then I put some colors on it. But basically, my point here is that you have, of course, we often look into OMT and needle exchange programs. We see the evidence base growing. It is still very high income driven. We see more research emerging from low middle income countries, which is really, really great. And just a little red box, because I really hope we're going to see more and more research around stimulant use, because we all know that we're still very much driven by an opiate dependency models, and in harm reduction, I think we still really need to innovate. There's some great sessions around stimulant use. I can really recommend go and do these sessions. This is really the future for harm reduction, in my humble opinion. We try to sum up the evidence in the new WHO NSP guide, which I will come to later, high NSP coverage in Europe was associated with 3/4 reduction in acquired hepatitis C. Other studies suggest that NSP can reduce HIV transmission by about half. I don't know why I'm looking behind me, there's another screen there. There's another one here. Right. I'm sure you recognize this slide because you've made them. Basically, what I want to say, if you combine OMT and NSP together, you have an even stronger impact on hepatitis C incidence. And similarly, when we look in HIV, combining more services together, higher coverage equals more efficient interventions. There's more evidence emerging from low-income country. I just pulled up those two, but there's lots of those, and we will hear many more in the coming conference. I quickly wanted to look into something else, because we obviously have a tendency of looking into infectious diseases, but I don't think we speak enough about other health impacts. This one I found very interesting. It talks about skin, soft tissue, and vascular infections related to injection. And it states that both on individual level and for public health level, it is beneficial to implement NSP, and it's cost effective. And I like to see as well in the future looking into other things than only hepatitis C and HIV. I wish I found similar pieces around overdose prevention and perhaps lung health related to smoking methamphetamine, but hopefully these pieces will come out in the future. Or if you're aware, please jump in after this presentation. Zooming in on a few interventions. This report came out by HRI this year, drug consumption rooms, the service model. There's just a growing body of evidence. These are some pictures from the drug consumption room in Paris. Growing body of evidence, really hoping that norm-setting agencies such as the WHO will be able to provide some recommendations in that area, because they're still not there. I'm not going to read out the results. This is a report I pulled up from the European Drug Agency. It states that drug checking services are increasingly relevant in that area as well. There is still a lot of uncertainty around evidence, but I also want to state that the absence of evidence doesn't mean that it doesn't work, and we still really need to put efforts in to generate more evidence. And I'm personally very much convinced that providing people with more information will help them to protect themselves better and protect their friends better. So I really hope to see more of these services as well, because it's still a very high-income service, high-income country service. I wanted to put a quick focus on some of the work that we spoke a lot about last INHSU, the innovative work that has been funded by UNITAID. But I also realized that we will speak about this quite a bit throughout the conference, so I'm going to skip through it a little bit, my 50 slides. So low-death space syringes, I think Annie's here in the room, she's leading a lot of that work from a qualitative perspective. What we learn basically is just ask people what they want. It's probably more important than the exact type of syringe. Ask what they want, make sure they're of high quality. That is essential for your NSP program. Second, long-acting depibrupinephrine. I kind of want to see it in a bigger perspective. Long-acting technology, of course, gets us very excited. And I think the really exciting thing about long-acting technology is seeing and exploring if that can be cost-effective in the view of all these funding costs. So can that be an additional tool that we're going to need in the future years? So of course it makes things easier. Instead of giving take-home doses to people, you'll have a one-time injection, which makes things all more practical. There's another element. We look into models of care. We are trying to find out if it is currently, in order to get hepatitis C treatment, of course you have an antibody test and you have a confirmatory test, and then you treat people. What we're doing is to see if we can skip that middle part, because this is sometimes very hard in context to maintain those laboratories doing these tests. We lose a lot of people at that point, so I'm trying to see what happens if we skip that test. Is that a way forward in complex environment? Not everywhere, but if you're in a low-income country where it is hard to maintain these laboratories, maybe that would be a way forward. So it's quite exciting work, and let's see what comes out of it. Okay, I think there were 35 slides in 10 minutes. A few more to go. New guidance, what we have up. This is not super new, but I'm sure Matt is in the room somewhere. I find this a really important guide. I just wanted to pull up again. we see an increasing role of the community emerge. I think it's so exciting, and it's really, if you talk about the state of the art of harm reduction, I think this is really talks to the state of art harm reduction. And in the coming years, with all these funding cuts, I think this is an even more important intervention coming up. So please have a look at this. There's a QR code if you want to pull it up, but I'm not going to give you a lot of time to. Sorry, too late. This is an INHSU exclusive. A technical document. The person responsible is right there from WHO, Dimitri. It's the first time, as far as I'm aware, that we show this document. This comes out of the recent funding cuts where I alluded to earlier on. We see a lot of services disappearing, and we also see people struggling maintaining OAMT services. And I don't know if you've ever been in a service where you're looking into rupture of OAMT services, but I promise you will remember. This is a life-saving treatment. People that suddenly have to do without, you knock their feet from under them, and this is really life-threatening. So WHO wanted to also provide some guidance in this area. Don't mistake this with the upcoming technical document about OAMT implementation. This is a document that states OAMT is an essential intervention, and it should be prioritized the same level as any other life-saving treatment. I'm very, very excited. WHO has been so clear about the language. OAMT should be, it's the first-line treatment. It should be offered to most people with opiate dependence, and this should be prioritized equally to any other life-saving treatment. I think it's a very, very powerful document that hopefully we will be able to use in the coming years to fight for OAMT, and I see a thumbs up. Thank you. Also, this puts quite a bit of a focus on embedding harm reduction services in a public health system. So OAMT is often depending on fluctuating donor commitments, and then, oh, you have a lot of money, and then suddenly you don't have any money. This should be part of a health system. It should be embedded, and we will see in another document, which I'm going to pull up right now. This is not only an INHSU exclusive, this is an INHSU pre-launch of a new WHO operational guide. This is the operational guide on NSP provision. Just as a disclaimer, I'm not talking out of name of WHO today, but I am for them publishing this at the moment. So what we've done is we've taken a modular approach, going from an assessment phase, implementation models, add comprehensive services, monitoring component, and scaling up. Two things that I really want to highlight here, which I think is really, really cool, that are now included in WHO guidance. One, on the assessment phase, it states very clearly, do not sit and wait till you have that fancy IBBS that's going to give you a number. We see so many places like, oh yeah, we want to put an NSP into place, but we don't know how many people we're talking about. Well, actually, if you don't implement, you will never know. And it states it quite clearly in this document that even if you don't know, you don't have clear numbers, still start implementing, and there's new evidence that will emerge. It also says that you don't need academic, complicated measures to come up with a number. The community knows a lot. Use that also as a source. Second, very cool stuff. Again, I'm pointing out Annie, which I don't know who sits here, but thanks also to her work and many people, Matt Southwell, many, there you are. Values and preferences is now an official component in an NSP program implementation. I think that is really, really awesome. Also, shout out to Unite, because that has also helped emerge this element. It is now part of the WHO guideline. It is, if you want to start an NSP program, well, guess what? Maybe you should ask people what they need and how much they need. Here's another one, which we're very keen to see in this document. We've spoken last year in INHSU. We had a policy day about this as well. Some of that work from the policy day is integrated in this guide. The targets. I mean, how many times have we spoken about the targets? 200 syringes, it's not enough. 300 syringes, it's not enough. So it states here very clearly, we should not confuse these global targets and should not use them as programmatic quantification. This is not a ceiling number. What counts is how many people, how many times people inject. That's as simple as that. So now it has a very simple approach. One injection equals one syringe. Actually, sometimes you need more syringes, but let's already start with this. That would be a good start. And what I'm very happy about, it states that by way of illustration, is not uncommon. This is part of the guideline. By way of illustration, it is not uncommon for a program to require an average of 3 syringes per person per day to accommodate a variety of injecting practices. This estimates translate to well over 1,000 syringes per person per year. So I really hope that we will see in the future years an increase of availability of syringes, and I hope that this could contribute to that. Same as I said before in the OEMT technical doc, we are really looking forward, more domestic funding, more inclusion in public health systems. You can't have an NSP depending on a policy of some external country somewhere. It's really important to make it part of an integral part. Now, I could talk another hour about this document, but let's leave it here for the moment. And I just want to say that it should come out in the next 3 to 4 weeks. Don't pin me down, but we have executive clearance, so it's going to come out very soon. So, to conclude, like I said, I think we've had quite a rough year, right? And maybe I just wanted to conclude a little bit with some of my reflections on this. Because, you know, sometimes you wake up and you feel a bit disillusioned, like, oh my God, you know, it's just time and again, and now we have a funding cut, and if it's not a funding cut, there's another policy thing that turns against us. So there's just 3 things that I wanted to give away. The first one, these are just pictures, nothing to do with what I'm actually saying, but the first is, you know, let's not forget how much progress we are actually making. This is a really hard time, we're all aware of it, but just have a look at, you know, look back 5 years, 10 years, look at the community role nowadays, how amazing progress goes. And we are in a very messy business, and progress isn't linear. So let's not see this as the way down, but this is just another setback, and we are making progress. Second, there is opportunity in crisis. Now, I know some of you want to kick me out of this stage because it's very hard to hear, but there is opportunity in crisis. And I think that, you know, we've always said there should be more domestic funding, but we will see right now that some countries will have to include this in domestic funding. So I really hope that this crisis pushes us forward in that regard. And the other really important thing in an opportunity in crisis is that we've seen time and again, the community is the one that keeps standing. They will still be there. So let it be a moment to push community leadership further. They are the future. And I think really, hopefully this, again, despite the crisis, will help us push forward further on this subject. And the last thing I wanted to say, look, if there's any movement that is equipped to deal with setbacks, I think it's us. In harm reduction, we are used to swim upstream. We fight against everything they throw us at all the time. Our movement is stronger than ever. And I think if it's anyway, let it be us when they throw this up. We are still here, we're not going anywhere, and we will keep fighting. I have 2 minutes left. I can't believe how many slides I've went through it. I wasn't sure if I was going to do this because I'm going to sound a bit like a hippie in front of a room of scientists, but I was looking at my presentation like, okay, if you're a frontline worker, you look at this like, yeah, okay, what do you want me to do? Slap people around with your new guidelines and your data and you know what? So I was thinking about this, and of course, and we will talk about it as we heard before, that behind all the graphs and the data and the guidelines, there's people, right? And I wanted to share just a little personal story about how, if you're a frontline worker, you find yourself in places where, honestly, it's very easy to lose hope at some point. This is the reality we look at. And at one time, I was in a country somewhere doing an assessment, and we were going to the first hotspots. And at that time, there was nobody there. There was only blood on the ground because the police had just come and they shot some people. So we moved on to the next place, and please don't take pictures of this, but we found a place where it was very difficult to find the difference between people and garbage. And this is a reality that we face, we work on. Frontline workers see this far too often, and it is very easy at these moments to just completely lose hope and be quite desperate. So we're standing in this place and feeling pretty desperate, to be honest. And at that time, there was somebody came up to me, he's like, this big smile and bright eyes, and he's like, oh, I've got to show you something. So I was a bit like, oh my God, what you got to show? And this guy came to me and showed this amazing, beautiful kitten, and it just broke my heart. But it made me realize, if you can find humanity, if you can find beauty in these places, we can find it anywhere. And I just wanted to say that if you maybe finding and bringing humanity and dignity in even these places, maybe that is the true state of the art of harm reduction. Thank you.